and I'd like to welcome Jess Simmons from UMass. So Dr. Simmons is an associate professor of surgery and endovascular surgery at UMass Chan Medical School, and she's the director for the vascular surgery residency at UMass as well. She's significantly involved in the VQI and serves as a vice chair for the Arterial Quality Council, and she's a chair for the Society for Vascular Surgery's Quality Improvement Committee. I've worked with Dr. Simmons on multiple projects around claudication, including the one she's talking about today, and I'm looking forward to this presentation. I'd like to welcome her to present. Thank you very much.
Thanks very much, Dr. Osborne. So I'll, as you indicated, I'm going to talk about one of my favorite clinical passions, which is claudication, even though I very rarely operate on it. And so we'll get started. I have no disclosures. And the outline for my talk is as follows. Basically, we're just going to start off with some background on what a clinical practice guideline is as it compares and contrasts with appropriate use criteria, because I think that's often a source of confusion for people that requires some discussion at the outset in order to really understand how these two documents differ and what they mean. Next, we're going to talk a little bit about what the rationale was for SVS to create an AUC on intermittent claudication, and then we'll dive into the findings and sort of a high-level overview of the CPG recommendations that are out there as well. Sort of intentionally put that one last in case we sort of run out of time, because I think that's probably the thing that people are most comfortable and familiar with, and the thing we could omit if needed. That being said, I think I will go under time, so that's my commitment. In terms of our definition, so again, I think it's really important to understand the key concepts of how a CPG and an AUC differ. And they both start with the systematic review of the literature, but the goals are kind of different for the two documents. So the goal of a CPG is to make clear recommendations either for or against a specific treatment, and to make a clear statement about the quality of the evidence that led to that recommendation. In contrast to this, AUC provide guidance on the relative likelihood of a benefit versus a risk for a treatment in the context of a particular clinical scenario. So really kind of something different that I think if I give you an example, it may illustrate that a little better. So if we use the example of aneurysm repair, a CPG might state that repair is recommended when size reaches 5.5 centimeters in men. Whereas an appropriate use criteria document on AAA may find that repair is appropriate for a 5.5 centimeter AAA in patients whose life expectancy is at least 2 years and they're independent with their functional status or some other sort of clinical scenario. And then similarly, for a patient with a 5.5 centimeter AAA whose life expectancy now is changed to be less than 2 years and to have poor functional status, an AUC may indicate that repair for that particular scenario is inappropriate. And for a patient with a 5.5 centimeter AAA and independent functional status, but short life expectancy, the AUC may deem the benefit to risk ratio indeterminate for repair. So kind of a very different thing. And so again, comparing and contrasting the two, they're both based on a systematic review of the literature and an assessment of the quality of the evidence. But it's then from there, it goes a little bit differently. And ultimately, what's most important is that AUCs and CPGs should not be in contradiction to one another. They should sort of align. But a CPG is not going to give a consideration for a total clinical picture. And the recommendation that comes out of those is typically phrased as a binary, either indicated or not indicated. Whereas an AUC assesses a treatment in the context of a common scenario and incorporates other patient factors, and they're graded as appropriate, inappropriate, or indeterminate in most cases. So, if I go back to that prior example of AAA, both documents would note that there's always an indication to repair a AAA at 5.5 centimeters, but that does not mean that it will always be appropriate to do so. So, oops, sorry, there's a slight delay. You told me that. So anyway, why would we make AUC? Are there times, that this is appropriate to do, circumstances in which a CPG is not sufficient? Well, I think we're all very familiar that there are many times when there really is lacking evidence to support certain behaviors. And so we're kind of only left with expert opinion in many cases in vascular surgery. And this gives us really sort of an opportunity to apply the RAND appropriateness method as a way of sort of imparting some degree of science to what is otherwise just expert opinion for many situations where there is no good evidence. And so that brings us to the SVS's project to create an AUC for intermittent claudication. Why intermittent claudication? I think probably many of us will recall from back in 2015, this article was published in the New York Times, and it garnered a lot of national attention for suspected inappropriate overuse of endovascular interventions for peripheral artery disease. There was an outcry from the public, from payers, from patients, and from our own SVS at the time regarding the need to explicitly define and justify the good and proper care that is expected of a physician. And in fact, our then SVS president, who was Dr. Lawrence at the time, focused his presidential address on these sorts of issues. He characterized several prior efforts, as well as ongoing SVS initiatives to address this issue of quality care in vascular surgery. In fact, he made 17 specific suggestions, if you go back and look at the details of that presidential address. And namely, he indicated that he felt that it was imperative that SVS needed to lead the way in creating appropriate use criteria. And intermittent claudication was chosen as the first disease process by the SVS for needing an AUC, sort of apropos of that New York Times article. So why not just use existing AUC that address claudication? There is an AUC document that was generated by several different societies, you see all listed there, that was published a while ago and was readily available in the literature. So why did SVS choose not to just go with this? Well, the document itself had actually caused a lot of consternation within SVS, as I understand it, and they ultimately chose not to co-endorse this document for several reasons, even though they were asked if they would like to. So only one of the rating panelists was a vascular surgeon. That was the first of several different concerns that arose. And there was also concern that these AUC were just far too liberal regarding the use of tibial artery PVI and claudicants. And this was something that was sort of a deal breaker, if you will, for many of the leaders of the SVS at the time. The document in general was just overall really a very general document covering a wide variety of clinical pathologies in several different arterial beds, including renal angioplasty. So, it really was not very specific to this topic of claudication, which I think all of us as vascular surgeons recognize is quite nuanced and probably does require a lot more discussion outside of, sort of the larger context of, angioplasty and stenting of any blood vessel. So, essentially, in essence, without our own document in the public domain, the SVS position on the issues was going to be either muted or silent. And we felt that IC management was nuanced enough that a singular focus on it was really warranted to do it justice. We also felt that panelists could be chosen for their specific expertise in this condition, as opposed to just a generic provider of all sorts of vascular interventions, but people with a true passion and interest in claudication, as well as a lot of experience with it, so that they could truly serve as experts on the topic. And there was a lot of background that I don't need to get into necessarily, but ultimately there are a number of different methodologies that can be employed for conducting an appropriate use criteria process, but SVS chose to go with the RAND appropriateness method. And the definition that RAND sets for appropriateness is that the expected health benefit exceeds the expected negative consequences by a sufficiently wide margin that the procedure is worth doing exclusive of cost. And so, the two basic questions, a writing panel was convened as the first step, a rating panel is subsequently convened, but the job of the writing panel was to come up with two questions or however many questions to sort of serve as the basis for this appropriate use criteria document. And so the first question was, what is the appropriate initial management for claudication? And then the second question was, after a trial of exercise therapy, what is the appropriate revascularization strategy for claudication? From there, round two was conducted. And again, this gets into a bit of the weeds, and I'm happy to go over any details if people have questions, but essentially a panel of experts is convened for round two, and then they went ahead and discussed and independently rated the appropriateness of a particular treatment in a patient presenting with a variety of specific clinical factors that were discussed and agreed upon by the writing panel. And what they came up with was 2,200 individual scenarios that they had to then go on and rate, which took over 15 hours over Zoom and spanned 2 days. And what was kind of most amazing from the perspective of these RAND appropriateness projects is that there was incredibly little disagreement relative to what is commonplace when a RAND appropriateness method is conducted. So less than 0.5% of scenarios met criteria for having disagreement in the rating amongst the expert panel. So again, it's beyond the scope of today's presentation, but I would just leave it as that is incredibly unusual and very compelling that the experts felt that there was not much debate about most of these things. There was a post hoc modification that was required along this whole process. So the original RAND terms, appropriate, indeterminate, and inappropriate, were used by the rating panel during its deliberation over Zoom. However, when it came time to sort of publish this and move it through the various processes and committees within SVS, it was noted that these terms, particularly the term appropriate and inappropriate, can carry a lot of different and highly charged connotations in current state, and particularly if these are then taken outside the context of the RAND appropriateness methodology definitions. And after a lot of really thoughtful deliberation and a lot of consultation with a lot of different people, the SVS decided post hoc to replace the term appropriate with B greater than R, indicating that benefit outweighing risk, and inappropriate with R greater than B, risk outweighing benefit. And these changes were intended to remove the positive and/or negative connotations, but still strictly align with the RAND appropriateness methodology definitions. So before I get into any of the results, I do want to say a few words about implementation of an AUC, because again, this it turned into a very charged issue that people felt very passionate about. And so I think it's really important, since AUC is relatively uncommon in the surgical literature, to just go over, how these should and shouldn't be thought of and used. These criteria are supposed to serve as a baseline framework upon which individualized patient-clinician shared decision-making can grow. And there are numerous limitations to these criteria. And certainly there are factors that are impossible to categorize and rate that need to be taken into consideration. It's important to recognize that these criteria are not absolute, and they should not be interpreted as a requirement to administer treatments that are rated as appropriate, nor should they be interpreted as a prohibition on treatments that are rated as inappropriate. And there will undoubtedly be clinical situations in which moderating patient factors not included in any of these scenarios will shift the appropriateness level of a treatment for an individual patient. So proper implementation of AUC really just calls for a description of those moderating patient factors. So in brief, the high-level overview of what these 2,200 scenarios yielded for results was for question 1, what is the appropriate initial management for claudication? Exercise therapy was appropriate in all the scenarios considered, not surprisingly. Increasing severity of lifestyle limitation tended to move some revascularization options towards an appropriate rating. And on the other hand, current nicotine use, while exerting less influence than lifestyle limitation, had the effect of making aggressive revascularization options less appropriate. And when these two modifiers were simultaneously present, the scenario was often rated as indeterminate. For question 2, after a trial of exercise therapy, what is the appropriate revascularization strategy for claudication? Clinical characteristics that tended to influence appropriateness here were, again, the severity of lifestyle limitation as well as current nicotine use. And again, they had opposite effects. Scenarios with a blend of these modifiers also in this scenario were often rated as indeterminate as a result of that. So the key findings actually are somewhat limited despite all of these tremendous scenarios. Basically, exercise therapy is a preferred initial management strategy for all patients with intermittent claudication. And for patients who have not completed exercise therapy, invasive therapy may provide net benefit in selected patients with intermittent claudication who are non-smokers, who are taking optimal medical therapy and are considered low physiologic and technical risk, as well as experiencing severe lifestyle limitation and/or short walking distance. Considering the long-term durability of currently available technology, invasive interventions for fem-pop disease should be reserved for patients with severe lifestyle limitation and short walking distance. In the common femoral segment, open common femoral endarterectomy provides greater net benefit than endovascular intervention. And in the infrapopliteal segment, invasive intervention for the treatment of intermittent claudication is of unclear benefit and may be harmful. So in a nutshell, that's what we got from our appropriate use criteria. And I encourage people to take a look at the document because it's extensive, but really if you look at that high level overview, I think it's pretty clear despite what looks like otherwise confusing tables. So I'll move on a little bit to clinical practice guidelines. So I just want to draw attention to the fact that these were published in 2015 now, so probably a lot of people are pretty familiar with them. But I think we can still kind of go over them. And as many people probably also know, they're currently being updated. And so I expect that in 2023, we'll get the updated version. But I'll go through a high level overview of the 2015 version for now. The clinical practice guideline for asymptomatic PAD includes a grade 1 recommendation based on level A evidence for smoking cessation. It also gives a grade 1 recommendation to providing education to patients about the signs and symptoms of progression of PAD. And they recommend against treating asymptomatic PAD, not surprisingly. But interesting to note, they actually declined to make a recommendation regarding the use of cardioprotective medications in a group of patients who had PAD that was completely asymptomatic. Looking at medical treatment for patients who now have symptomatic PAD with claudication, they assessed as a type 1A recommendation, smoking cessation, use of statins, and use of antiplatelet agents. They also recommend, though less strongly, optimizing diabetic control with an A1C goal of less than 7 and use of beta blockers when there is another indication for them. With respect to exercise therapy for claudication, it is recommended as first-line therapy consistent with what the AUC came up with. And that specific definition of that is a supervised exercise program at least 3 times per week, at least 30 to 60 minutes per session, and at least 12 weeks long. Home-based exercise therapy is recommended when supervised programs are not available, but with a lesser degree of evidence to support it. And the CPG also recommended specifically that continuation of exercise therapy after revascularization was important. In terms of intervention, it is recommended only once conservative measures have failed and when a clinically meaningful improvement is believed to be durable for at least 2 years. And this is something that the appropriate use criteria rating panel spent a lot of time thinking about, because it's obviously a very difficult and challenging prediction for a clinician to make when they're trying to consider whether or not to intervene on someone. But, again, in all good faith efforts, this should be what the surgeon's expectations are before intervening. And then in terms of how the recommendations are rolled out regarding type of revascularization strategy, it gets a lot more complicated. So they're made kind of according to anatomic segment of disease largely mirroring task-based recommendations. And for the aortoiliac segment, angioplasty and stenting is recommended for more focal iliac disease. And they recommend assessment of the common femoral artery and endarterectomy for any hemodynamically significant lesion. But none of the recommendations in this chart are based on grade A evidence, unfortunately. For femoral popliteal disease, the recommendations again sort of mirror task-based algorithms, with focal and intermediate length lesions being treated with angioplasty and stenting as the recommendation, and more diffuse disease recommended for treatment with open bypass. These guidelines do endorse the use of preoperative vein mapping and the use of greater saphenous vein whenever it's available, and that includes cases when the target is the above knee popliteal artery. They do not recommend treatment of isolated tibial disease for claudication, again, consistent with what the AUC ultimately recommended. In terms of post-intervention medical management, optimal medical therapy should be continued, not surprisingly. And for bypass, they specifically recommended lifelong antiplatelet therapy, whereas for endo intervention, dual antiplatelet therapy is recommended, but only for 30 days. Post-intervention surveillance, Clinical evaluation and ABIs are recommended indefinitely, although what you see is that there is no defined interval for these. And that's true for all revascularizations, both endo and open. For bypass specifically, they also recommend graft duplex, although they do not make that same recommendation for peripheral stenting. So in summary, AUC and CPG are intended to be complementary with different purposes and different uses and sort of different language associated with them. The summary from both of these is that there is good evidence and agreement for conservative therapy as first line for claudication, and that smoking cessation, exercise therapy greater than 3 months, statin and antiplatelet are sort of the pillars of that conservative therapy. Interventions should be considered according to the degree of disability the patient is experiencing in combination with the vascular segment affected and the likelihood of durability of the repair strategy. And there will be an update to the CPG that's due out probably in 2023. And the likely changes it will build out a bit on sort of medical therapy in the era of DOACs and PAD Xarelto and those sorts of things, as well as some other modifications. And I think most importantly, every time I do anything related to PAD, I am struck by how much room for improvement there is in terms of the evidence that exists in the literature.